I have no disclosures. As you all know, hypoxic ischemic encephalopathy is the leading cause of death and disability despite neuroprotective treatment options in the neonates, such as cooling. At times, it can be a clinically challenging diagnosis, and despite the established diagnosis, the treatment options are limited. And when we are going to go forward for those treatment options, we have very short time window to initiate the treatment, 6 hours as of time of birth. The diagnostic criteria set forth by the American Academy of Pediatrics and American College of Obstetrics follow 4 major criteria: profound metabolic or mixed acidemia in umbilical artery blood sample, if obtained, Apgar scores 0 to 3 after 5 minutes of life, evidence of neonatal neurological sequelae such as seizures, coma, or hypotonia, and multiple organ involvement, such as involvement in the kidneys, lungs, liver, heart, or intestines. As you can realize, these are all clinically based diagnoses. The challenge is the cord gas needs to be obtained within the first hour of life, and at times it may not be available. Then the neonate's blood gas can be used, but it has to be within 1 hour of life. Assessment of neonatal seizures can be challenging. The typical clonic seizures that you do see in the adult population or older children are typically not seen in the neonates. The evidence of seizure can be simple lip smacking or twitching of the eye. So what is the role of imaging in HIE? To provide diagnosis in clinically challenging cases or in already established cases, early identification of brain injury is quite critical for risk stratification, prognostication, family counseling, assessment of possible adjuvant therapies, or even refinement of the existing hypothermia protocols. Many etiologies have been discussed for a potential cause of hypoxic ischemic injury in the neonate. And when we're talking about a newborn neonate and ischemic injury, we need to think about the entire package involving the mother, the fetus, the cord, the placenta, the amniotic fluid. Let's look at the mother. Systemic inflammatory response syndrome and fetal inflammatory response syndrome has been actively discussed in the past 2 decades with their inflammatory effects to the fetus. Any type of inflammatory process, such as maternal sepsis, has been identified in some children with HIE, or processes that induce inflammation in the fetus, which may usually involve multiple organs, have been discussed. How about the placenta? The typical cases are either with partial or complete placental abruption, or in some cases, small placental volume or perfusion defects in the placenta, or chorioamnionitis, the infectious process that involves both the amniotic fluid and the placenta itself. Prolapse of the cord may impair blood flow to the fetus, thus result in hypoxia, basically, or wrapping of the cord around the fetal neck, or difficult delivery, especially prolonged second stage of labor, or a combination of all of these may result in hypoxic ischemic injury. So these involve pre, peri, and immediate postnatal events as a potential cause. Regardless of the multiple potential etiologic factors, once the hypoxic ischemic injury hits the brain, there is depletion of oxygen and usually high utilization of the glucose, resulting in depletion of the glucose as well, leading into anaerobic metabolism. This anaerobic metabolism, once it is set, the primary energy failure is right there. So by the time the patient gets their diagnosis, the primary energy failure is already set. We cannot reverse what happened. But what we can do is during the reperfusion time that leads into the second energy failure, where inflammatory markers and excitatory amino acids are released, we do have a therapeutic window between the 2 energy failure stages, and that is when we do typically initiate the cooling protocol. So what basically determines the pattern or degree of injury is the duration and severity of impairment of blood flow and perfusion to the brain in those areas that are metabolically active and more mature and myelinated. That seems to identify the pattern of injury in these infants. Let's look at the term neonate first. We did talk about the inflammation during the second energy failure. The free radicals and excitatory amino acids are out there, and there may even be prenatal triggering, like as we talked about in the fetal inflammatory response syndrome. Volpe, a brilliant person in pediatric neurology, has described different patterns of injury and correlated them with the type of insults based on the published literature on animal models, looking at the monkeys and baby sheep. And when he was categorizing the pattern of injury, he did primarily pay attention to the cerebral cortex, subcortical and deep white matter, deep nuclear gray matter, and brainstem. And the more the involvement, the more severe the injury. Typically, in cases where the cortex, white matter, deep nuclear gray matter, and brainstem are involved, these are severe, prolonged insults, resulting in moderate to severe motor and cognitive deficits. If the cortex and white matter are involved, plus minus deep nuclear involvement, these are more so moderate to prolonged insults, resulting in pretty much moderate motor cognitive deficits. If you do have primary pattern as brainstem and deep nuclear gray matter, then that usually indicates a severe abrupt insult. And in those cases where the primary involvement is in the white matter, such as periventricular and central white matter, usually mild to moderate insult leading into mild cognitive and sometimes motor deficits. Now let's look at some example cases. The first case was a full-term neonate who was delivered emergently by C-section due to placental abruption. Had the full clinical presentation of HIE with a low pH, less than 7, increased acid-base deficit, more than 16, cyanotic seizures. This is the first head ultrasound obtained immediately after initiation of cooling. Anterior fontanelle coronal image, you do appreciate the overall global increased echogenicity of the brain parenchyma. The ventricles are effaced. The basal ganglia and thalami also demonstrate increased echogenicity. So we do have an overall global edematous pattern of the brain, and resistive index measurements in the anterior cerebral artery demonstrate low resistive indices measuring down to 0.45, supporting the impaired autoregulation in this baby. Pay attention to the area of the cingulate gyrus. You do see profound hyperechogenicity of the leptomeninges immediately surrounded by relatively dark appearing cortex over here, and the subcortical white matter is relatively higher. So this is a so-called pronounced gray-white matter differentiation in the acute phase of the cerebral edema in the setting of HIE. Same baby at day of life 5. Now we're looking at the MRI. On the left-hand side, we are looking at the upper row T2 weighted images, profound, diffused, increased T2 signal involving the white matter, the cortex, the basal ganglia, the thalami, and also the brainstem, the anterior portion of the pons, has a very high T2 signal too. And all those areas represent restricted diffusion in a very diffuse and symmetric pattern. Moving on to the second pattern, involvement of the cortex, white matter, and plus minus deep nuclear gray matter. In this patient, this is one of the most typical patterns of HIE, as demonstrated on MR imaging, one of the classic patterns. And what we do see here is involvement of the ischemic injury in the mesial temporal lobes, higher up, extending into the ventrolateral thalami and posterior basal ganglia, posterior lymphoma to internal capsule, posterior centrum semiovale, and going into the perirholandic region. This was a near-term neonate who was delivered for a prolonged second stage of labor, so moderate prolonged injury was identified and had the classic features of HIE with seizures, apnea, and low APGAR scores. Another patient, term, almost 40 gestational weeks. We're looking at the head ultrasound at day of life 3. This is immediately upon cessation of cooling. And now in this patient, again, we do observe the generalized increased hyperechogenicity of the brain parenchyma, the basal ganglia. About the third day of cooling, you start seeing opening of the ventricles with somewhat reducing mass effect. And at this point, the pronounced gray-white differentiation is no longer observed in this particular case, although it was present on day of life 1, which I'm not presenting here. So the injury has further progressed, and now we can see evidence of involvement in the cortex in the head ultrasound as well. Same patient at day of life 8. Now we are seeing the hyperintensity of the cortex on T1 weighted imaging on the mesial temporal lobes, basal ganglia, thalami, and frontal cortices. And at day of life 8, we continue to see the restricted diffusion in the areas with injury. We do know that pseudonormalization is delayed in the neonates. Typically in adults, it is called up to 6 days of life. In the neonates, we do know that it may extend up to 8 days of life. And additional cooling may further prolong up to 10 days of life. So these are the things to keep in mind in terms of the evolution of the ischemic process and how things are different in the neonate. This was published by a French group, first author Bednarek in Neurology, a great article that talks about the temporal evolution of pseudonormalization. This is another infant, 40 gestational weeks. Patient presented to our hospital with history of placental abruption. At the time patient was with us, they were already beyond the time of intervention. First head ultrasound. The most striking finding, the area that demonstrates altered echogenicity, is centered in the brainstem. This is a coronal image that shows the area of the cerebral pedunculus, and you do see diffuse, profound hyperechogenicity. Extending into the thalami, the central portion of the thalami, clearly. And we do have the reduced RI values, again indicating impaired autoregulation. At this point, when we saw this head ultrasound, although we didn't see much of abnormal echogenicity in the white matter or the cortices, we did notify our NICU folks that this is indicating a severe type of injury, and we also told them that we do expect to see fast progression of disease. And here is their follow-up head ultrasound, day of life 2 and day of life 3. From day of life 1 to 2, you can see how fast the infarcts involve the basal ganglia, and you do see that at day of life 3, everything is much more confluent. Basal ganglia, thalami, somewhat, periventricular regions are also involved. About day of life 4, this child died. This is the type pattern of injury that is associated with the highest mortality rate. The so-called white matter injury. This was an example of a case, term infant, that had decreased fetal movement and was found to have nuchal cord wrapping around the neck times 2. Upon delivery, amniotic fluid was meconium stained, Apgar scores were low, pH was borderline, and MRI was performed at day of life 2. Pay attention to the white matter. These white matter areas in the subcortical periventricular regions and also involving the corpus callosum, both in the anterior and posterior locations, demonstrate clear evidence of restricted diffusion. Additional finding is this huge, large parenchymal hemorrhage in the right parietal lobe and a smaller one on the left side. This patient was noted to have liver dysfunction, and additional hematologic abnormalities can be seen, like DIC can be observed associated with HIE. So you can see additional hemorrhagic injuries in these infants. In this particular one, we saw it in the setting of primary white matter disease. So when we look at the brain MRI in the newborn, when we see areas of restricted diffusion in a somewhat generalized pattern, either involving the white matter or the cortex, do we only think about HIE? We have to consider other entities in our differential diagnosis, and I will quickly touch base on the most common and typical ones and try to identify the features that help differentiate from HIE. First, we're going to look into some examples of metabolic injury. This was a full-term neonate that had an uneventful vaginal delivery. Child was doing well, normal Apgar stores. Then later, during the first day of life, patient had an acute onset of seizures, clinically easily identified seizures. And when MR imaging was performed, we did find the restricted diffusion pretty much confined to the posterior parieto-occipital regions extending into the splenium of the corpus callosum. This is a typical presentation of hypoglycemia-related metabolic injury. And typically in these patients, the mesial temporal lobes are not involved, which is a common area of involvement in patients with HIE. And although this is like the typical presentation, more anterior involvement has been also seen and reported in patients with hypoglycemia. Another metabolic disease, maple syrup urine disease. This is an autosomal recessive disorder of branched amino acid catabolism. The catabolized neurotoxic material accumulates in the brain, and this usually takes at least a couple days. So patients present with refusal of feeding, feeding intolerance, or seizures, typically at day of life 4 or later. And their area of involvement is somewhat similar to HIE, but some areas that we don't see involved, such as cerebellar white matter, is an area of involvement in the maple syrup urine disease. Brainstem is profoundly involved, and there is posterior thalamic involvement going up to the plic and also to parts of the central centrum semiovale. So involvement of the cerebellar white matter and usually lack of involvement in the mesial temporal lobes seem to be different, as well as their clinical presentation. Infection is another consideration. We have 2 different patients here. Patient 1 was a full-term infant that presented to our hospital at day of life 11, primarily with seizures and feeding difficulties. Due to this symptomatology, patient was referred for MR imaging. On diffusion-weighted image, you can clearly see the restricted diffusion involving the insular cortices, inferior frontal lobes, mesial temporal lobes, and temporal pole in a somewhat symmetric fashion. In addition, on post-contrast imaging, those areas that had restricted diffusion demonstrate evidence of leptomeningeal enhancement, and also pay attention to the profound diffuse increased T2 signal of the white matter, indicating a more generalized inflammation going on in this brain. We did think that this area of restricted diffusion was highly suggestive of HSV meningitis, and this was clinically proven to be so. Another patient, full term, again, presenting in the 2nd week of life with seizures and feeding difficulties. MRI was prompted by this, clinical presentation, and the most striking findings in this infant is the ventriculomegaly. There is at least moderate degree of ventriculomegaly. Periventricular white matter has high T2 signal. And when we look at the post-contrast T1 weighted image, we clearly identify the enhancement in the subependymal lining and also along the leptomeninges. There is layering debris in the occipital horns, as evidenced by restricted diffusion of the material, indicating that this is infectious in origin. Plus, we do see the cystic changes in the periventricular white matter, perhaps from the vasculitis, perhaps from the septic emboli that took place as a complication of this patient with meningoencephalitis. And further cultures proved this case to be GBS meningitis. Another full-term patient, they presented at day of life 2 with right-sided jerking. Presentation is later in the 2nd day of life. So this presentation would be very unusual for HIE, upon admission of the patient to our hospital, we performed a head ultrasound. And on this head ultrasound image, you can appreciate the focal asymmetric hyperechogenicity in the left parietal region extending into the basal ganglia, clearly to the caudate head. And there is effacement, mass effect on the ipsilateral ventricular system. This raised concern for a potential stroke, likely originating from the left MCA distribution. MR imaging was performed, and we clearly found out that this was a patient with a left MCA stroke, the most common area of stroke in the newborn neonate. This was a recent case that came to us, which made us, scratch our heads a little bit as we were going over this case in our weekly conference. Full-term neonate, clinical history is significant for teenage pregnancy, and the baby had a C-section for prolonged labor, and presented to Hopkins at day of life 2 regarding persistent seizures. First row demonstrates the diffusion tracer image, and second row shows the corresponding ADC maps. And you can see the profound restricted diffusion in the supratentorial brain. But one thing takes our attention, different than the previous cases I have shown. The left side seems a little bit more swollen, and there is also asymmetric restricted diffusion in the left basal ganglia and some less effect on the ipsilateral ventricular system. So the question became, is this HIE? Is this stroke? Which one came first? What do we do? When we were discussing this case, Terry was also involved with this case, and he said, we have to dig into the history more. Probably we don't know something about this baby. That, we received it from another institution, further communication was established, and what we found out was the mother had a history of MRSA during their pregnancy, and the placental evaluation was suspicious for chorioamnionitis. Perhaps this is an example of a case where the insult was initiated during the fetal life, maybe fetal inflammatory response syndrome, which further had contribution from a thrombotic event, is evidenced by left MCA thrombus over here and reduced venous drainage in the left parieto-occipital lobes. So at times, by looking at the pattern and location of injury, we're able to come down to a more narrow differential, and sometimes maybe we have multiple different etiologies playing into the same patient. In our limited time, I'm going to quickly glance over the preterm neonate and try to show examples of cases where the preterm injury is a little different compared to the term. The reasons for difference is all related to the degree of maturation in the entire preterm infant. Immaturity of the lungs would probably contribute to poor oxygenation of the entire neonate. And the limited immature vasodilatory capacity of the cerebral vasculature makes it more vulnerable for bleeding, more fragile. During the reperfusion state of this ischemic hypoxic insult, preterm brain tends to respond with more hemorrhagic conversion of the ischemic injuries. And as we all know, germinal matrix is a very highly metabolically active, still prominent part of the brain during the preterm time period. The immaturity of the central nervous system immune system further plays into how things progress over time, as we will see in the examples. Volpe very greatly identified how the germinal matrix hemorrhage spectrum works in the preterm brain, and he did give further insight to the more global effect in the brain development. The typical germinal matrix hemorrhage initiates in the caudothalamic notch. Usually that's where the remnant of germinal matrix sits. However, germinal matrix, as you all know, initially develops in the subependymal lining. You can see hemorrhages originating from the temporal regions as well. Regardless, typical involvement in the caudothalamic notch may further progress into an intraventricular hemorrhage, and impaired drainage of the intramedullary veins in the white matter around that area may result in venous ischemia and may have hemorrhagic conversion, the so-called periventricular hemorrhagic infarcts. The entity is not just limited to that, though. So this germinal matrix subventricular zone distraction not only involves the immediate vicinity of the brain parenchyma, but also impairs the overall development of the cortical and thalamic development. It is also contributed by the injuries to the axons. And the periventricular hemorrhagic infarctions and disease processes involving the white matter distract the pre-myelinating oligodendrocytes, which also result in impaired myelination in these preterm infants. So it is much more extensive than the simple local germinal matrix hemorrhage itself. It is more like a global issue that involves the networks between the thalamus and the cortical development, and also the axons. The very low birth weight and very young, extremely low gestational age preterm infants seem to be very susceptible for brain injury. This was a 25 gestational week-old infant. They presented to our hospital. And on the first row of images, coronal image from the anterior fontanelle showing immature brain development with a simplistic appearing gyral sulcation pattern. The ventricles are somewhat prominent, but a little bit smaller on the left side because the baby was sleeping on their left side, which reduces the size of that ipsilateral ventricular system. And we do pay close attention to their cerebellum because preterm brain is very susceptible with cerebellar injuries. You can have hemorrhagic injuries in the cerebellum, not all too uncommon. So make sure to obtain posterior fontanelle and transmastoid views in all age groups, especially in the preterms. So cerebellum was okay, brain looked okay, day of life 1. Day of life 2. Patient has a rapid drop in their hematocrit. Concern was raised for intracranial hemorrhage. We did the head ultrasound, and you can see the profound, large area of hemorrhage in the region of the germinal matrix, filling into the frontal horn. Further, hyperechogenicity in the periventricular white matter. This is the so-called area of the periventricular hemorrhagic infarction. The contralateral ventricle is also enlarged, and there is also evidence of hemorrhage on the other side. At this point, this area of hemorrhagic infarction is not expected to heal, and evolution of the ischemic injury, hemorrhagic ischemic injury in the preterm usually does not involve much of gliosis. The tissue just disappears, becomes a hole in the brain. And here is the same infant, a follow-up image. Obviously, that huge hemorrhage resulted in post-hemorrhagic hydrocephalus involving the infra and supratentorial brain, required shunting. Baby was already shunted and came for a follow-up due to altered mental status. The area of the hemorrhagic infarct in the right periventricular white matter is a hole right now communicating with the frontal horn. And it is not only the white matter, but you can also see that the overlying cortex in that area is very thin and abnormal looking, indicating the explained mechanism of injury between the thalamus and cortex that happens during the germinal matrix hemorrhage spectrum. How about PVL? PVL is more like the generalized, diffuse form of white matter injury in the preterms and may be evidenced by focal ischemic changes. As we can see in this 34 gestational week infant, this patient had fulminant liver failure and aortic coarctation, and you can clearly see the cystic changes in the parasagittal white matter and periventricular white matter regions. Those areas of white matter that are typically the watershed distribution are quite vulnerable for any type of injury. So what do we do once we establish the diagnosis? If we're dealing with a neonate that is 35 gestational weeks and older and 1,800 grams and heavier, and if you establish your diagnosis within the first 6 hours of life, then this baby has a chance to qualify for the cooling protocol. In our institution, we do a 72-hour long whole body cooling. And what do we expect to do in these babies once we know their diagnosis? We look at the final brain damage. How does MRI really play into in further developing neoadjuvant therapies or further refinement of the hypothermia protocols. To that end, we did do a collaboration study with our anesthesiology and critical care team, where they monitored the cerebral autoregulation via near-infrared spectroscopy. And during their 36-hour, 72-hour recordings, they identified the time periods and areas where the brain had the most level of autoregulation. And those areas with worse autoregulation correlated with worse degree of ADC measurements in these children. This gives us the hope that upon refinement of the autoregulation assessment, we may be able to adjust the blood pressure values and things that play into autoregulation during the hypothermia treatment, which is very critical. So what is for the preterms? Preterms less than 35 gestational weeks do not qualify for cooling, and there is growing evidence with animal studies that the hematopoietic cytokine erythropoietin has a high value in neuroprotective and neuroregenerative healings in the brain. This is a widely used agent to treat the anemia of prematurity, and anti-inflammatory, anti-excitotoxic, antioxidant, and anti-apoptotic effects have been nicely shown in animal models. Also, the dose-dependent effect and safety measures had already been established, and our hospital is part of a phase 3 trial where we're going to be looking at the imaging of these extremely low gestational age preterm infants that are treated with EPO, and hopefully we will have a better understanding of how well it contributes to the healing of hypoxic ischemic injury in the brain in the preterm infants. In conclusion, hypoxic ischemic injury is a complex cascade of events resulting from multiple different etiologies. Within this brief 30-minute time period, I only had the chance to glance through some of the important aspects of it, but obviously there is much more detail to it. I hope I was able to deliver the importance of recognizing certain patterns, and certain patterns how they relate to the severity of the insults. Also, we need to pay attention to the degree of brain maturation. Preterm and term are different, and timing of imaging has a huge influence on our interpretation, as this is an ever-evolving injury. Imaging, especially MRI, is quite helpful in narrowing down the differential diagnosis, and multidisciplinary approach. Having a multidisciplinary team is quite critical in identifying these cases and providing the accurate differential diagnosis. And on that note, I would like to express my gratitude to our Neurosciences Intensive Care Nursery Program, our chairs of the program, Drs. Francis Northington and Terry Heisman, has been extremely influential in their leadership in pulling together this program, and has provided incredible advancement in the care of these children. And thank you very much.